Quantifying diastolic dysfunction by echocardiography is essential for identifying heart failure with preserved ejection fraction. The clinical standard is based on 2016 ASC EACVI guidelines, though emerging research in 2025-26 emphasizes the integration of left atrial strain for higher sensitivity. In patients with a normal left ventricular ejection fraction, that is more than or equal to 50%, and no known heart disease, the presence of diastolic dysfunction is determined by four primary variables: average E by E prime ratio more than 14, septal E prime velocity less than 7 cm per second, or lateral E prime velocity less than 10 cm per second. Peak tricuspid regurgitation velocity more than 2.8 meter per second. That will correspond to a TR gradient of nearly 32 millimeters of mercury and around above 40 millimeters of mercury systolic pressure in the pulmonary artery. Left atrial volume index more than 34 ml per meter square, indicating that the left atrium is dilated. Less than 2 positive criteria will be interpreted as normal. Exactly 2 positive criteria is indeterminate, and more than 2 positive criteria will be taken as diastolic dysfunction. Once left ventricular diastolic dysfunction is confirmed, or if the patient has a reduced left ventricular ejection fraction or structural heart disease like left ventricular hypertrophy, the focus shifts to grading the severity and estimating left ventricular filling pressures. Grade 1 is impaired relaxation. The physiology is that left ventricle takes longer to relax, but filling pressures remain normal. Mitral inflow E by A ratio is less than or equal to 0.8 and E velocity less than or equal to 50 cm per second. Clinically, these patients are typically asymptomatic at rest but may have dyspnea on exertion. Grade 2 is pseudonormal pattern, in which the physiology is moderate diastolic dysfunction